Hello everyone, and welcome back to Rapid Review Rounds. In today's session, we're going to break down a topic that's increasingly important in Canada, Lyme disease. This is a classic infectious disease you need to know inside and out for your MCCQE1. We'll walk through everything from the tick that causes it to the key treatment protocols. Let's begin. So, what is Lyme disease at its core? It's an infection you get from a specific type of bacteria, a spirochete called Borrelia burgdorferi. The key here is how you get it. It's transmitted through the bite of a very small insect, the black-legged tick, also known as the deer tick. As you can see from this map, endemic areas in Canada are expanding, so recognizing this disease is more critical than ever. Think of it as a great imitator, an illness that can present in many different ways by affecting various parts of the body. Let's look at how this happens. A person is bitten by an infected Ixodes tick. Now, a crucial point for your exam and for clinical practice is that the tick usually needs to be attached for at least 24 to 36 hours to transmit the bacteria. This isn't an instant process. Once inside the body, the spiral-shaped Borrelia bacteria travel from the skin bite and spread throughout the body via the bloodstream and lymphatic system. The symptoms of Lyme disease are caused by our own body's inflammatory response to the bacteria in whatever tissue they happen to settle in, be it the skin, the joints, the heart, or the nervous system. The clinical presentation of Lyme is classically divided into 3 stages. It's very important to know these. Stage 1 is early localized disease. This happens days to weeks after the bite. The absolute hallmark here is the skin rash, erythema migrans. This is the famous bullseye rash. It's usually not painful or itchy. Alongside the rash, patients often feel like they have the flu. They're tired, feverish, and achy. Stage 2 is early disseminated disease. If left untreated, the bacteria spread. This is where you see some of the most tested complications. The highest yield neurologic finding is a bilateral or unilateral facial nerve palsy. For the heart, the key complication is AV block. Patients can present with dizziness, syncope, or palpitations. Stage 3 is late disseminated disease. Months to even years later, the main manifestation is arthritis. The classic presentation is a swollen, painful knee, a large joint monoarthritis. Late neurologic symptoms can also occur, but late arthritis is the most common feature. Diagnosing Lyme disease can be straightforward, or it can be tricky. Here is the most important rule. If a patient presents with a classic erythema migrans rash and has a likely history of exposure, that is enough for a clinical diagnosis. You do not need to do blood testing in this case. You diagnose and treat. However, for patients with later stage symptoms, like a mysterious heart block or a facial palsy in the summer, we turn to a blood test. The standard is a 2-tiered approach. First, you get a highly sensitive screening test, like an ELISA. If it's positive or unclear, you then get a highly specific confirmatory test, the Western blot. Remember, it takes time for the body to make antibodies, so testing too early in the infection can give you a false negative. The treatment for Lyme disease is quite effective with antibiotics. Your workhorse drug, and the one you should remember for the exam, is doxycycline. For early disease, like the bullseye rash, a 10 to 14-day course of doxycycline is standard. It's also the first choice for facial palsy and Lyme arthritis. Now, when do we use IV antibiotics? Think of severe disease. If a patient has meningitis or a high-degree heart block requiring hospitalization, the treatment of choice is IV ceftriaxone. A key exception to remember, for pregnant women and young children under 8, we typically avoid doxycycline and use amoxicillin instead. Let's synthesize this with a classic vignette. Let's break it down. We have a young man in the summer. He has a history of hiking in an endemic area in Ontario. He presents with a flu-like illness and, most importantly, a classic erythema migrans rash. Even though he doesn't remember the bite, the rash is pathognomonic. So what is the next step? Remember our diagnosis rule. In the presence of a classic EM rash and exposure history, this is a clinical diagnosis. We do not need to test. Therefore, the most appropriate next step is to initiate treatment. The correct answer is B, prescribe a 14-day course of doxycycline. It's important to remember that not every round red rash is Lyme disease. Let's quickly consider a few mimics. Bacterial cellulitis is typically tender, warm, and painful, features that are usually absent in an EM rash. Ringworm, a fungal infection, classically has a raised, scaly border and is quite itchy. And a simple hypersensitivity reaction to a bug bite happens much faster, within hours, and is usually intensely itchy. Differentiating these is key for avoiding misdiagnosis. All right, that brings us to the end of this rapid review. To summarize the key points for Lyme disease, remember it's caused by the spirochete Borrelia burgdorferi, transmitted by a tiny Ixodes tick that must be attached for more than a day. If you see that classic bullseye rash, erythema migrans, your job is simple. Make the clinical diagnosis and start treatment right away without waiting for tests. For later disseminated manifestations, the classic triad to remember is a facial nerve palsy, an unexplained AV block, and a swollen knee from monoarticular arthritis. I hope the straightforward review helps you feel more confident about tackling Lyme disease on your exam. Thank you for joining the Rapid Review Rounds.